power on.
Is that better? Well, I don't do this much, so. So at any rate, my wife and I, Gail, moved here about 7 years ago, and setting the stage, if you will, for today's discussion. And by the way, this is an open discussion. It's a small group, so we almost kind of want it to be a round table. We'll have question and answer at the end, but if you do have a question while we're, don't feel that you have to wait till the end of the program if you're engaged with a question. At any rate, a little over a year ago, a number of us here at Montreux worked to raise money for what we call the Nevada Cares Campus, which is essentially our homeless center, which is down on 4th Street. And I've already had some questions as to how that's going, and while that's not the focus of the conversation here today, I would simply say go down and walk the river, the 2 or 3 blocks in the downtown area, and it is enormously different than it was 2 years ago. And I think that is the most direct evidence that you will see as to the progress that the money that you donated has done. But that's a first step. Through that process, I became aware through talking to various professionals that the estimates run that between 75 and 95% of the people who are experiencing homelessness are also suffering from some level of behavioral health issue, otherwise known as mental health. So it's pretty easy to draw the connection that if that high a percentage of the homeless population has these issues, that we need to be looking at behavioral health and addiction if we have any hope of solving the homeless problem and returning many of those people to productive members of our society. So many of you who may have done the tour of the campus last year may have seen the Hope's tiny homes. So through that work last year, I became aware of the Hope's organization initially because of the tiny homes that some of you have seen. By the way, that was the first housing development or housing unit sponsored by a healthcare organization in the United States. As the CEO of Hope's, she has been the CEO for 11 years, and over those 11 years, she has taken the organization from a clinic that served 600 patients to today a multi-level organization that serves over 12,000 patients. There's a 38,000 square foot facility on 5th Street that she got built, and as of this year, fully paid for. Last year, they opened the Hope Springs project, the tiny homes that I referred to. Earlier this year, a clinic on Bell Street was opened, which focuses exclusively on behavioral health. And earlier this summer, we broke ground on a new 40,000 square foot facility, which is adjacent to the Nevada Cares campus or the homeless shelter. So Sharon is really an amazing CEO. This is an amazing track record of success over her tenure. So at this point, I'm going to turn it over to Sharon.
Thanks so much. Can you hear me? Yes. Okay. So happy that everybody's here today, and I'm going to be the moderator, so I'm going to try to keep these 3 in line, but I'm not always the best at that, but I'll try my best. And please, like Cliff said, if you have any questions at any point, just raise your hand, and I'll try to make sure I look up and notice you, and we can engage in conversation. It doesn't have to be a one-way conversation for us at all, okay? All right, I want to introduce our panel, but before I do that, I wanted to spend a little bit of time just giving you some, painting the picture of behavioral health and mental health right here in Nevada and nationally. So in Nevada, 1 in 5 people over the age of 12 have a mental health condition. In Nevada, we rank 12th highest in the nation for suicide. In the Silver State, the age-adjusted rate for deaths from suicide in 2020 was 19.2 per 100,000 population, which is higher than the national rate of 14 per 100,000. On average, roughly 632 Nevadans die by suicide every year, and approximately 12% of the suicides were among young adults ages 18 to 24 and youth ages 10 to 17. Suicide is the second leading cause of death among young people and the ninth leading cause of death in the Silver State. From 2017 to 2020, there were 14,949 emergency room visits with a suicide ideation code included in the visits for age 10 to 24. Among the age group of 10 to 17, there's been a steady increase in suicide ideation from 2017 to 2020, with the highest group rate of 519.4. The need in Nevada is so great, and we see this on a daily basis at Northern Nevada Hopes. We are 47th in access to mental health care in the United States. We are 51st in the shortage in mental health professionals compared to need. The Nevada Children's Report Card gave us these are not things to be fantastic about, but gave us an F for alcohol and drug treatment, gave us an F for access to mental and behavioral health care, and gave us an F for juvenile justice and mental health services. We, of course, have people that have a higher usage of ERs and violence and prison and people experiencing homelessness because of behavioral health issues. So I'm glad we're here today to have this important conversation. Let me introduce our panelists, and we'll get started with some questions. Okay. First, let me introduce Dr. Kim Hopkinson. She is the Research and Evaluation Manager at Social Entrepreneurs, Inc., a Nevada-based consulting firm that has been actively supporting both the state's and Washoe County's efforts to implement a crisis response system. Welcome. Next, I'll introduce Dr. Kenneth Cole. Dr. Kenneth Cole is the former Dean of the College of Education and Human Development and Professor of Counselor Education at the University of Nevada, Reno. Cole came to Nevada from Boise State University, where he serves as Associate Dean of the College of Education and directed the Institute for the Study of Addiction, which was named Distinguished Program of the Year by the International Association of Addictions and Offenders Counseling in 2009. He is currently working from the Provost Office at the University of Nevada, Reno to develop and implement and direct the University Community Behavioral Health Collaborative to increase access to behavioral health services for underserved communities and facilities in Northern Nevada. Ken, a licensed clinical professional counselor himself, clinical supervisor and researcher, specializes in helping vulnerable and high-risk youth. He has authored and co-authored more than 90 peer-reviewed journal articles and book chapters. And lastly, I'd like to introduce Dr. Davis Coelho. She is a clinical psychologist and the Chief Behavioral Health Officer at Northern Nevada Hopes. Kristen is also on the clinical faculty of the University of Nevada, Reno School of Medicine, and is an appointed member of the Washoe Regional Behavioral Health Policy Board and serves on the Technical Advisory Committee for the Washoe Crisis Response Implementation System team. That's a mouthful. Okay, so this is our panelists for today. All right, let's start with our first question, and we'll start with you, Kim. So we just heard some sobering facts about where Nevada ranks regarding mental health. What is Nevada doing to help address these issues?
Thank you. Can everyone hear me okay? Great. So Nevada is doing quite a bit, but what I want to focus on today is what Nevada is doing to stand up a crisis response system here in Nevada to help everyone who is experiencing a behavioral health crisis to make sure that they have immediate or as immediate as possible access to services that are tailored to what they need. And so Nevada has been working to stand up that CRS, so I'll call the crisis response system a CRS just to make it a little quicker, for a while now. But I'm going to give a little bit of background on some things that happened at the national level that have kind of pushed this forward. So in October of 2020, a piece of national legislation passed which mandated the switch from what's currently a 10-digit number for suicide prevention hotline to a 3-digit number, which is 988. And we're going to talk about 988 in a follow-up question, so I'm not going to go into it much today, or much during this first question. But what happened as part of that is states were able to apply for a grant to create an implementation plan. So think of it as an action plan, strategic plan, implementation plan, however you want to think of it, for being prepared to launch 988, which happened yesterday. So the official launch for 988 was yesterday. And then also doing work post-launch, because we all know that just turning on the system, turning on that one phone number, isn't going to solve the problem. There's a lot more that goes into it. So Nevada received that grant in January of 2021 and convened a planning coalition of stakeholders in Nevada to begin work on, again, developing that implementation plan. What Nevada decided to do is to not focus just on 988, even though that's what the grant was tailored for. We said, you know what, let's actually use this to develop an action plan to stand up the entire crisis response system. And that has 3 main elements. It has many more elements, but I'm going to talk about the 3 main ones. So the first is 988, and that's a number to call. So that's if you are, or someone you know is experiencing a behavioral health crisis or suicidality, you can call, text, or chat that number. So you may also text it from your cell phone. And be connected with a trained person on the other end of the line who can help provide the support you need right over the phone. Data shows us that about 80% of folks who call are able to be de-escalated just via that call, and they don't need follow-up services. So that's pretty significant. And then the second part of a CRS system is mobile crisis teams. And that is someone to come to you. The way that it helps my brain, and sometimes other people to think about it, is if you think of the public safety response that we currently have in place, right? You call 911, and if you need assistance, they dispatch the correct type of support to you. You can kind of think of it that way, but it's a behavioral health team that's dispatched to your location through that mobile crisis team. And then the third element is called a crisis stabilization center, and that's someplace to go. So again, you can think of it as the equivalent of an emergency room, although it's very different, so I don't want it to seem like, we're trying to replace public safety supports in any way, but sometimes that analogy can help kind of put things in perspective of how they'll work in the system. And so that allows people to go to a place that is only serving folks that are experiencing behavioral health crises. So this means that folks who cannot be de-escalated over the phone or through a mobile crisis team are hopefully not ending up in an ER when that's not where they should be. They're not ending up in jail or another incarceration facility when that's not where they should be. And so that's the crisis response system in a nutshell, what it should contain. It is going to be work. It is going to take some years to get this stood up, but Nevada has been working hard for a while now to do so. And here specifically in Washoe County, you guys actually have a team that's working on their own implementation plan of how to stand up elements of the CRS in Washoe County specifically. So that's something just to consider, how different regions are working at different speeds, and that we expect different elements will stand up in different times over the next few years, but all the work is being done simultaneously. So it's not, well, we wait till we stand up 988, and then we'll do mobile crisis teams, and then we'll do CSCs. All the work is happening simultaneously. So that's what a CRS is in general, and then I will, I think, keep the rest of my stuff about 988 for when we have our 988 question. So I'll pause there and see what other folks want to jump in with.
Any questions so far? Okay, that's exciting news for us in Nevada, so looking forward to learning more about that. Thanks so much, Kim. Next, let me ask a question of you, Ken. How effective are mental health services, and what are some of the examples of what's working in Nevada?
Thanks, Sharon. Well, when we talk about mental health services, typically we're talking about group counseling or therapy, you could use that word, group therapy, individual therapy, family therapy. Sometimes we're talking about training on particular issues like trauma-informed training, but mostly it's when we talk about mental health services and delivery of them, we're talking about therapy and its various iterations. So one of the questions that we have at the university, of course, that has to be answered is, are these services effective? Does it work? And the answer is yes. There's all sorts of research, all sorts of clinical trials that indicate that going in to talk to a professional is effective in that people feel better, they function better. And it's to the tune, now one of you might say, well, it's not everybody. No, the number is 75 to 80%. Do we need to work a little harder for that 20 or 25%? Probably, because what's going on there? Yet, those are good, consistent numbers. And another question that's often asked is, well, how long? If I come in once, do I feel better? Well, you can, for sure. There's a lot of research that says that helps. But typically, people feel like they're functioning better after 8 sessions. And then depending on person severity, if they can sustain longer, then that's often very helpful. So we sort of answer that question. So in Nevada, and sort of my role, I guess, my little niche is we're training these professionals. How do we make sure we train them well? Also, how do we deploy them to help the people that need the most help? And Northern Nevada Hopes does a tremendous job with that. Yet there's pockets all over Northern Nevada where we are that indicates we are not delivering services to the people that need the services the most. Their accessibility is lousy. So what we're trying to do, and I'll give you a few examples, is leverage the university behavioral health training programs, and let me give you some examples. We have a really good, of course you might say I'm biased, I guess I am, but they're all accredited, so that tells you a lot. We have a really good psychiatric training program, not training that many people because of accreditation limits, yet it's good. We have a nurse practitioner psychiatric emphasis training program that's fairly new. Our PA program, physician assistant program, is going to have a psychiatric emphasis. So if we think about this sort of, those of us in the business tend to think about it along a continuum. The Kim's trying to catch the crises, and then we settle that crisis down, then we can do some treatment. You're trying to, I don't want to speak for you, but the public's view is more of sustained support and help with people that need the most help. So anyway, along this continuum, we have all these training programs. I'll give you a few more examples. Marriage and family therapists, clinical mental health therapists, all licensed folks in the state of Nevada, or any state, if they choose to go somewhere else. Substance abuse counseling people. So we have these folks we're training. We're trying to match them with the most vulnerable populations in our community. What we have, and this may be no surprise to you, is sort of a bifurcated system. People that have the ability to pay get services, but now they have to wait 2-3 months, right? People that don't have the ability to pay, either through insurance or out of pocket, they're in big trouble. And you're really the only group that really addresses that head on. I mean, the rest of us are trying. And I think there is a movement. So that's maybe where I want to go with the question is, we're at the university working hard, meeting to leverage this sort of dynamic where we can place interns with helping our most vulnerable. We do have a family clinic. Some of you may know the med school has a very good family clinic in town. We are now partnering with Renown, and there's a lot of talk about how do we reduce this bifurcation that we have, and with a whole lot of people that can't get good access to services, even though we know these services work.
Thank you so much. We appreciate that, and interested to talk to you a little bit more about some programs coming up. I'll ask Kristen the next question, but before I ask you that, I'm going to go off script and put you on the spot.
Go for it. I'm ready.
I'm just curious, a lot of us hear the term behavioral health and mental health, and is there a difference between those two?
Yeah, that's a great question. I was actually going to talk about that, so thank you. So when we talk about behavioral health is actually sort of an umbrella term, and underneath that we typically think of two different things and a lot of different levels of care. So the two services, the two groups under behavioral health, you think of mental health treatment, which would be things like depression, post-traumatic stress disorder, eating disorders, stress management, grief and loss, the mental health realm. And then there's substance use disorders, right, which is sort of the new term for people struggling with addiction of various sorts. And so that would be alcohol use disorders, opioid use disorders, stimulants, pathological gambling, etc. So those are both underneath this umbrella, and behavioral health, when we use that term, typically encompasses both of those. And again, under that umbrella, there's a lot of different levels of care. So there is traditional, what we call outpatient services, which we think of as your more traditional, going to see a therapist, going to see a psychiatrist. And then there are kind of higher levels of care, depending on the intensity of what you need at that moment to meet the struggle that you're having. So it ranges from outpatient care up through what we call intensive outpatient, partial hospitalization, inpatient treatment centers, and then residential treatment centers. And all of that is kind of captured by the term behavioral health in these kind of conversations.
Thanks so much for that clarification. Now for my scripted question for you. Northern Nevada Hopes is a federally qualified health center. What is that, and what role do FQHCs, or federally qualified health centers, play regarding mental and behavioral health?
So Federally Qualified Health Center, FQHC, is a community health center that receives federal funding. That's kind of at its most basic. That federal funding allows the community health center to serve people that wouldn't be able to access services otherwise, because of geography, because of finances, and because there are other barriers for them to get those services. And the federal funding allows the FQHC to provide wraparound services. So that will typically include not just see your primary care doctor, but case management if you need that, access to resources for housing or transportation. So it's a broader like wraparound. I sort of envision like the arms sort of wrapping around that person going, okay, that's great, you got to see the doctor for your pneumonia, but how do we make sure the pneumonia doesn't come back tomorrow because you can't afford your medication and you don't have heating in your house, right, and you can't come back for your follow-up appointment. So it's this wrapping around them to make sure we can actually address the problem effectively. So when it comes to behavioral health services, FQHCs play a key role in, again, serving those people who couldn't get those services otherwise. And most FQHCs have some sort of behavioral health care. They don't have to, but most do, because we know that mental health and substance use disorders are key to somebody's overall health, right? If you have untreated depression, then you probably aren't going to take your medications the way you should, and your chronic health condition won't get better. If you have an alcohol use disorder, that's going to cause a lot of health problems, right? That seeing a primary care doc just for your physical health isn't going to address. So some FQHCs have a small amount of behavioral health, and some have very broad, kind of comprehensive services. And so an FQHC might be in a rural location, right, where that is the only health center for 100 miles. And so they have like the one therapist that can see as many people as they possibly can. Some FQHCs are in a more urban area and again try to represent this more broad continuum of services to address the needs. But the barriers, again, often are financial in nature. And so FQHCs typically have to have a sliding fee scale for people that are on Medicaid, for people that don't have insurance or have, a not great insurance that, covers the basics but won't cover you to see a therapist, or that don't have any kind of insurance at all. And using Northern Nevada Homes as an example, at any given time, about 17% or 18% of our patients are actively homeless at that moment. And I don't know what percentage are at the federal poverty level, but you probably know that off the top of your head.
Yeah, about 80% or 200% or below.
Yeah, about 80% of our patients are at 200% or below the federal poverty level. So Northern Nevada Homes is kind of a good example of what the FQHC exists to serve.
Thank you. Any questions so far? Yes?
Can you please tell me what FQHC stands for?
Yes, sorry, I went through that fast. That's a federally qualified health center. It's just a government acronym for, we get a little bit of federal funding to be able to do these services. Yeah.
I have a question that's somewhat generic. We're getting a lot of specificity here, which is great. Why are we F, and F?
We can all try to answer that a little bit. Yeah, that is the question, isn't it?
Yeah.
And it is a multifactorial answer. So there is partly a lack of providers, right? So it's great for people to be able to recognize they have a problem and try to see somebody, but if you can't get in to see somebody, right, because there aren't enough providers, there you go. It is a lack of services for people who don't have good insurance, good payment availability for them. It is small training programs, right? We have great behavioral health training programs across the entire state, but they are small and they never keep up with the need, right? We have a higher degree of mental health and substance use disorders here in Nevada than we do in many other states, and so the need outweighs the resources most of the time. I'll shut up and let you guys speak to the pieces you know about too.
I think too, I would guess some of you are not native Nevadans. You're maybe from back east like me. I grew up in Philadelphia, Pennsylvania. And many of the states back there if we think about how they've matured over time, they've matured in their systems, in their mental health systems, in their training programs, in their university training programs, in everything, and how they fund people that are most vulnerable. So if you think about, a state like Vermont, which is always number one in access to mental health care, that's a state that's been around a long time, and good for them. They've developed a system over time that really can take care of people. Nevada, these other western states like Nevada are Johnny-come-latelys, and we are building a system. We really are over time. And we're trying to do it quickly because these western states like Nevada and Idaho and Wyoming and Utah and Montana are states that are growing very quickly with people coming in with needs. And that's different than the states back east, as many of you know. So we are trying to quickly close these gaps that,
So are you saying it's not a reason? I'm sorry, I didn't want to get in front of you though.
Please.
But are you saying it's get that as an issue vis-a-vis allocations of the budget, the state budget?
That's, any help you can provide would be wonderful.
So I'll tell you, I'll jump into the state realm, so you please feel free to jump into this if you know more than I do. But one of the things Nevada did a couple of legislative sessions ago is develop behavioral health policy boards. So there are 5 of them across the state, one for Washoe, one for Clark County, one northern, and us, western Nevada, one for the rurals, and I'm forgetting one. Do you know what it is?
So they're broken up in a little bit of an odd way.
Right.
Yeah, you basically covered them.
Okay.
Yeah.
So these policy boards were actually designed, and people are appointed to them. I'm on the Washoe one. People are appointed to them by the legislators and various people because they bring some particular expertise as a behavioral health provider, as somebody that represents insurance companies, as someone that represents the community, the mentally ill, a lot of different requirements. But what we do is we get to inform policy at the legislative level. And every legislative session, we get a bill draft. Each board gets one, right? So that we know that every legislative session, there is at least 5 high-quality, well-thought-out, from the experts, behavioral health legislation being pushed forward. And so far, the policy boards have only existed for 3 years now, 2 legislative sessions. But so far, we've had great success having a legislation passed with some tweaking, right? Political tweaking that always happens. But that is something that Nevada did that I think is making a difference.
So they're funded pieces of legislation, they're not just empty.
Well, we do still have to apply the fiscal note, right, and have to pay attention to that. So no, there's not automatic funding.
Yeah, it takes time. Here's an example of one win. The state has funded 94 mental health professionals to go into schools and work with youth that can access mental health services right in the school. That's a win, and it's going to build slower than we'd like to, but that's a win. In the state, these groups, these consortiums, these committees really are leveraging the state to say, look, we need you to pony up, and here's specifically, as you said, how you can pony up. We always want them to pony up a little more, but
Are they able to fill those 94 spots?
it depends on where they are. One of the things that we're trying to do is provide some support. This is a university initiative through telehealth or teletherapy in the areas where they really can't recruit anybody, which, no surprise, is going to be in the rural areas. We know that. They have trouble recruiting mental health professionals. Washoe County, Clark County, not so much, but a lot of the other counties, yes.
The only other thing I was going to add as well is that Nevada has also been leveraging federal funds that have been available. And I will, when we talk about 988 in a moment, I'll talk about some other legislative funding or legislatively supported funding that will be available soon for 988. But Nevada has been leveraging federal monies, especially those that have become available during the pandemic, like ARPA funding, to help support, exactly what you guys are talking about, specifically with elements of the crisis response system, and then also receiving other grants as well. So there are private donors that are coming in that have been supporting this in terms of private donors being foundations, and then state and federal grant funds as well that are being utilized.
You talked about funding to the state of Nevada, so how much of that goes specifically to Washoe County? And how much will Northern California? And how much is Clark County committed that obviously it's a bigger area, get a larger piece of the pie, but do they get a much larger piece of the pie? And are we straggling a little behind that because of that?
Yeah, I don't know the exact percentages and numbers, and it depends typically on the initiative and what you can justify in terms of where the money should go. But yeah, I mean, typically it is a larger area. Some of the Fs that we have on our report card are dragged down by Clark County because the need is so great there, and the lack of resources is so intense. I would say some of them, Washoe County might get like a C- or a D on its own. But yeah, we try to be, those of us that have any influence at all, hopefully ever, try to be strategic about what kind of funding, where the funding gets allocated, but then it goes to the people that are, applying the funding.
One of the eye-popping stats, so that's why I had Vermont on my mind, because I was looking at stats. Vermont is the top-ranked state for serving adults treatment for adults with mental illness. but their percentage of adults who have mental illness who do not receive treatment, this is the #1 ranked state in the country, 43%. So 43% of the adults that need mental health treatment in Vermont, #1 ranked state in our country, only 43% don't get treatment. And in states like Nevada, it's more like 65%. I mean, those are eye-popping numbers nationally. So it's not just Nevada, and I think COVID, of course, has exacerbated this. It's around the country.
So one of the things that you're talking about is available resources. And I understand that for a clinician to come into the state of Nevada, they have to be recertified or re-accredited. So even if they're coming just across the border from California, and there's this period of time that they're not able to work due to this requirement, is there any chance that that would change, or what is the benefit of this?
Yeah, the
I'm
licensure
laughing because
between-
it's a challenge.
It is a big challenge. It is a big challenge. And it also hinders us in terms of telehealth because, right, you can provide, someone in a state like Vermont that has many, many providers could be providing services via telehealth to a rural community that has none, but the licensure is a challenge. Some of the licensing boards are actually developing coalitions across states, kind of interstate compacts, where they will recognize each other's licensure with sort of a minimum amount of paperwork involved, essentially. The psychologist board, my board, has done that. And I think some of the other boards are also working on it. So that's one way we're trying to address that.
Yeah.
It's hard.
Yeah, I know the counseling board, and there's a substance abuse board. All these boards are, that's one of the challenges. They've all grown up kind of independently. So
Yep.
COVID has helped in really, especially in a state like Nevada where there's such a shortage of behavioral health professionals, that groups are now, licensing boards are now working together, which 10 years ago, that would have been unbelievable.
I can speak to that real quick too. I moved here 2 years ago. I'm licensed in California as a marriage family therapist. Also Nevada, Utah, Arizona. It took me 3 months to get licensed here in Nevada, which is actually relatively quick.
Yeah.
And it also depends on when graduation's happening, when people are submitting hours, depending on how many people are in the office.
Yeah.
So it can vary quite a bit.
Yeah.
But Nevada is actually probably one of the quickest to do it.
Yeah.
Out of all the states I've ever been licensed in.
Wow.
It's better than it was. Yeah.
So do we need lobbyists, or what do we need?
Yes.
I shouldn't. I'll just say one more quick thing. I'm probably talking too much. Some states have really stepped up in terms of funding for big ticket funding. I don't know if Nevada can afford that right now, but it wouldn't be bad to ask some legislatures. Texas is an example. They've stepped up with huge. I think I read $340 million the state of Texas is providing for this kind of
So many more
work.
babies, that's why.
They
Excuse me.
they do, yes, they do. But even if we did a percentage, that would still be a good chunk, even if we took a percentage of their population. Colorado has really stepped up, so it's possible. There's a movement nationally with this.
Yes.
We have very limited knowledge of this, I'll be clear from the start. But we were involved in a situation where we brought somebody in for a mental health, behavioral health, whatever it was, situation. And to be quite honest, it was interesting to hear the federal qualified requirement. When we left after what seemed to be 72 hours, I literally said, oh, they just checked off everything we needed to get federal reimbursement. I didn't feel like anything really was a benefit to it. We were almost screaming to get us involved, and the door was shut. And I know so the question behind that is, a lot of these folks, there's so many of them obviously, I don't know personally how they're going to get through it on their own. And because of part of the solution.
Yeah, thank you. I mean, what you're describing is not uncommon, unfortunately. It is tricky. The question of confidentiality is tricky, I will tell you, as a practitioner, right? Because there are situations where the people would not seek care if they knew that other people would be aware that they were seeking care or be able to be involved. And there are crisis situations where you know the person, because of what they're struggling with at that moment, is not making good decisions for themselves, right? Cannot advocate for themselves, and really need a family member or a caring other to be there to advocate and support for them. And if they are an adult, they have to give permission for that, right? And so you get into this bind where if the person is feeling particularly private about what they're going through, or feeling paranoid about having other people help them, or like any number of reasons, that they would not give permission, even if that is the thing that will help them the most. And the professional field of behavioral health, mental health, we are bound by that confidentiality. It has to be the person's choice if they're over 18, or in some cases younger in some specific cases. But it is hard. It is very hard. As we build these systems to try and wrap care around them that doesn't have to involve their family or their friends or somebody if they won't let us, essentially. And I know, again, as a provider, as a therapist, a lot of my conversation with people is talking with them about who can we get involved, right? Who would you be comfortable getting involved? And this seems really important for us to let your family know what's happening in this specific area. Can we just bring them in and talk about like this one thing that seems like they could really help? Like there's a lot of that conversation that always happens behind closed doors to try and get people involved. But it is hard, it's tricky. And it's incredibly frustrating when you're the person that is trying to help and is having the door shut in your face.
There's so much stigma, still surrounding behavioral health services. And so, you think about when your 23-year-old goes out and goes skiing and breaks their leg, well, grandma's going to hear about it, and aunt and uncle and everybody else is going to hear about it. But somebody goes into the hospital for a hold, there's still so much stigma that it's, let's keep that quiet. And so the more as society that we can talk about it and just acknowledge that we all have people in our families and in our lives that struggle with behavioral health challenges, the easier it will be for people to make those choices to have other people involved in their care also. Okay, we'll get down into the weeds just a little bit again because I'd like to hear some more about 988. So could you just talk to us a little bit about what it is and how it will help behavioral health and mental health crises?
I can. Before I jump into that, I didn't want to interrupt you guys as you were giving such great answers, but I had some thoughts as I was sitting here quietly, which I wanted to share. I think one of the things when we talk about how to address a lack of resources or things like in the rurals, it's hard to have practitioners that want to be in the rurals for many reasons, as we can imagine. The first thing I wanted to say is that work is going on all across Nevada. We have folks from the rurals, from Clark, from Washoe that are serving on our crisis response system implementation group, our planning coalition, and all of our work groups. So I just want to make sure it's clear that while I pointed out what the great work Washoe is doing, there is great work happening all over the state, which is what needs to happen, right, to stand up a statewide system. But I wanted to give a quick example of one of the ways that the state has been able to, look at some alternate modalities for types of support. I can't remember who, but one of you mentioned telehealth. And so recently, it just was announced in June, Nevada actually got a private foundation who is now funding iPads that will provide telehealth supports to law enforcement that are engaging with individuals who are experiencing a behavioral health crisis or who could benefit from speaking with a trained clinician on the other end of the iPad. So that's something, right? Like it's going to be a lot of baby steps, but there are things happening. So I don't want it to give the impression that it's 0 or nothing, it's 0 or 100. Like there's a lot of steps in between. But that was pretty exciting that grant just got announced, so I wanted to share that with the group. And now I'll talk 988, which I'm very excited about, because I think that's why I'm here. For the most part, I think I'm here to talk about 988. So, as I mentioned earlier, 988 is seen in large part, it's going to be a large part of an entry point to the crisis response system. It's not the only entry point. People will be able to utilize other elements of the system directly, but it's a way that folks can, if they want, confidentially or even anonymously seek help over the phone, over a text, to receive supports or possibly to get connected or to get referrals to other organizations that can help them as well. So that's the intent of 988. It is replacing the current 10-digit suicide prevention hotline number. That number is not going away. So any promotional materials that have it, it's not like if you call that number, you're going to get a dial tone, whatever that is when you call and it can't be connected. That will still be live, but 988 just makes it easier, right? We all know 911. It's just an easy number to remember. Hopefully everyone will remember 988 as well. And that it may help to address the stigma you guys were talking about, that if we talk about it widely, the same way we talk about other public safety resources, like 911, people will start going, oh yeah, I actually texted 988. I had this issue, I was having a panic attack, or whatever it would be, that you felt like could be treated by 988 versus 911, and I called or I texted them, and it was a great experience. And so giving people the opportunity to talk about it in that way, I think could be really helpful. But it did go live yesterday. Here in Nevada, the calls are going to be answered by Crisis Support Services of Nevada, who is an organization that's been in existence since the 60s. They are the current lifeline in Nevada that answers the suicide prevention hotline calls. They also man a lot of other calls, such as the sexual assault line that they manage as well. So lots of great experience, a lot of great history with this group that'll be answering those calls. 988 is intended to be collaborative with other elements of the CRS system as well as the public safety system. So that's one thing to note that I think I glossed over a little bit when I was talking about the CRS in general, is that this is complementary and it will be integrated. The ideal system is integrated with public safety as well. These are not two systems operating in vacuums, but they are constantly in communication. With things like 988, what we're hoping to have is the opportunity for 911 dispatchers to be able to transfer calls and vice versa, which they currently do. If someone calls 988 or what will now be 988, and there was a medical issue at play, 911 is getting looped in, law enforcement is getting looped in. So that I think is important for folks to know. It's not an either or, which is what we're hoping the system will do. And so that's in general what 988 is intended to do. I have a lot of details, but I don't want to overwhelm you guys with that, so I'm happy to provide them if people are like, no, we want more details, just let me know. But in a nutshell, that's what 988 is intended to do. What I will note is we often do get questions about funding, so I did want to note that in the last legislative session, Senate Bill 390 was passed, and the governor signed it in June of last year. And that provides a funding mechanism for the 988 system. And so we have a lot of grants, like I mentioned, a lot of grants, a lot of things that are coming in to support standing up the system, but what about sustainability? Because we're obviously not going to charge people to use this system, right? You're not going to get charged if you call or text 988. What is going to happen is there will be a surcharge placed on all phone lines in Nevada. And it is up to a maximum of 35 cents a month. The fee has not been established yet. The surcharge hasn't, we don't know what it will be, but it will not be more than 35 cents a month per phone line. And that's going to help provide a sustainable funding mechanism. And that's very similar to how 911 is funded as well. Just so folks know, if you ever look at your phone bill, that's what you'll likely see moving forward soon. And so that is, in general, what 988 will do. One other thing I'll note that is pretty exciting as well is that the number will be put on K through 12 school IDs starting this fall. So kids that have a school ID at a public school, at charter schools it's optional, private schools it's optional, but public schools will need to put that on. And we're also working with NCHI to get that number put on all college IDs as well. So that, if students, young people, youth, or anyone going through what can be a pretty stressful situation, right? Going to school, getting a college degree and beyond. will have the ability to just look at their ID and go, oh yeah, there's help for me. I can call 988, or more likely, I can text 988 and get connected with somebody. Yeah.
How else is the word getting out about 988?
Yeah, that's a great question. So I will say at the national level, states were asked to soft launch 988. That's the best way I'll put it, is they asked the states not to do really rigorous promotion before the system went live yesterday, because they didn't want people to start using it before it was live. In some states, if you had tried to access 988 before yesterday, you might not have gotten through, which would be the worst possible option. Here in Nevada, calls actually have been going through, so if you had called or texted on 988 in the last few months, you would have been connected, you would have been rerouted. But again, nationally they asked us, please don't promote it. So that's why you guys haven't seen it on billboards, PSAs, anything like that. Now that it's launched, the State of Nevada, the public information officers, they've developed a promotional plan that's going into effect. One of the first steps in that promotional plan was getting it on the IDs. So that's like the first step, because that's going to hit tens of thousands of individuals. And so starting in the fall, you should see 988 promoted more widely in a variety of means. I do also have flyers that are over there, so people are welcome to take those. If we run out, I do have some older versions that still have the 10-digit number on them, as well as the 988 number, so I can hand those out as well. They're still accurate. Yeah.
Is it being marketed as suicide prevention line, or is it a behavioral health line?
It's actually being, the way I understand it is specifically mental health crisis is the wording they're using. In Nevada, we have expanded that a bit, but it is mental health crisis or suicidality is the specifics around how the national marketing is saying are the most appropriate calls for 988 for tests.
Originally talked about kind of this three-tier stage, I guess, crisis prevention.
It's the crisis response system has the three elements: 988, the mobile crisis response teams, and the crisis stabilization centers.
Okay, so the stabilization center, how does that interact with, say, what HOPES is doing or Renown is doing in ER, and will there be collaboration between those three resource centers and
So ideally, yes. Ideally, again, everything is integrated in the system, right? Crisis response is not over here operating in a silo. It is connected to every other system that's appropriate. And so one of the ways that CSCs sometimes are developed is they'll actually be part of a hospital structure, but there'll be a separate entrance and a separate area or a separate unit, so that folks who are, I have to imagine being, very stressed, experiencing a behavioral health crisis. The clinicians here can speak to more to what that is. Having them come into an ER, I know how stressful an ER can be if you just go and get you think you sprained your ankle or something. So having them go to a space that is more geared towards the crisis they're experiencing is what the CSCs are designed to do. But in many cases, one of the models is a co-model where they would be located at a center. Renown is actually exploring that currently. So Renown is exploring how to potentially add a CSC or CSCs to some of their locations. Yeah. That's information I just got 2 days ago, so I'm glad you asked that question, or I would have forgotten to mention it.
Will they be divided up, or do you know if they're going to be divided up from adults and adolescents or children?
That's actually a question that the work group has been discussing for the last several weeks, at least at the statewide, and you're on the Washoe specific work group, so I'll speak to Washoe specifically.
Yeah. So in Washoe, they are going to be divided. There will be a separate one for children and adolescents and one for adults. Speaking to the earlier question, the way it is very intensely partnershiped. All of the people, all the main behavioral health players in the community are at the table, are represented in these development plan that we've been doing for the crisis response system. Because what we do not want to do is duplicate services in one area and keep a gap in some other area, right? So we need to make sure that it's very well integrated. And part of the crisis response system is a center eventually that the calls will come into. That will have sort of a dispatch high-tech hub that knows all of the resources in the community, can push a button and find out that this hospital has an open bed for somebody in a psychiatric crisis, or this person might best be met in a crisis stabilization center. The difference with crisis stabilization centers is somebody goes to those for less than 24 hours. And it is like we call the living room model, where there are recliners. It's not beds, it's not rooms, there's recliners. There are counselors on site right there to help the person stabilize in less than 24 hours and then give them follow-up resources versus, say, an inpatient hospitalization, which would be longer than that. And so all of these components are in play along the continuum of care. And what we've done in Washoe now, because I'll brag on our committee, we are ahead of the national curve. We're actually boogieing through this crisis response system planning. But what we're transitioning now with the 988 up, and we have most of the pieces of the crisis response system at least planned, right, not implemented, but planned, is now we are moving into the next phase, which truly is just focused on the integration piece. How are all these going to work together? How do we make sure that the 911 emergency response system and behavioral health response system are working in tandem? How do we make sure that the agencies that are providing mobile crisis response are going to cover the entire geography, not just different pieces of the geography? And then how does it interact with systems like Northern Nevada Hopes that has a whole continuum of behavioral health care already? So that is the whole next phase of what we're doing on the crisis response implementation team for Washoe.
I think that's such a great regional example of what, because Washoe is doing really good stuff right now. So you were right to brag on Washoe. And I think to brag on the state of Nevada in general. I know it may sometimes feel like this is a very large undertaking, and it is. We have to eat the elephant one bite at a time, which is what we're trying to do. And I will say that at least our implementation plan, when we submitted it in January, we got some pretty major kudos from the grantor, because every state or territory was eligible to apply for the grant, so I think there were like 52 that went out. And I don't know the exact statistics, so I don't want to say it wrong, but we were in the top like 5, I think. Like they were very happy with what we produced. So again, I know it can feel sometimes daunting, but Nevada is making progress and working. And I think one of the things that's going to make the system, what's going to make it work so well is that it is a win-win endeavor for every single element that's involved in it. One of the things I didn't mention earlier, because I said I wouldn't get in the details, but I really like this detail, is that Houston has been doing something similar. So in Houston, they have, for about a 5-year period, so I'll end it in 2021 because that's when I have the data from. For those 5 years prior, they had their crisis call center. So it wasn't 988, but they had a crisis call center that was integrated to some extent with their first responder system. So law enforcement, fire, dispatch. And over those 5 years, they were able to divert 10,500 calls that would have resulted in a dispatch. So if those calls had come in to the normal 911, they likely would have had to dispatch either fire or law enforcement to that individual. But instead, they transferred them to the crisis call center, and those folks were served by entering that into that model. That equated to about $6.4 million in savings to fire and police. So just in Houston, just over 5 years. So if you expand that out over the national population, there's a lot of good that can come from this.
Yes?
I have 2 questions. Young people that you are you finding students that want to go into these service delivery systems? That's one question. And the second question is, we're talking about youth, we're talking about adults. Where do the seniors, where do the gerontological fall in?
We'll talk about that.
I could take that, being a senior myself.
Older than you.
Thank you. Well, it's stigma, really, and that's changing, as we know. That about 10 years ago, we put a gerontological counseling emphasis into our curriculum, and nobody was interested, because there really wasn't much of a market for that 10 years ago. Now there is, and there will continue to be. That's a growth area for sure. I still think there's stigma around agencies that work with seniors to offer that as a service, even for seniors to pay for that. Just say, we can set you up with a therapist if you want. That's not happening as much as it should. It will happen over the next 20 years. We're going to see that as a growth area for sure. And just quickly to your point of can we find providers? Yeah. These are highly regimented training programs, and I think you want them to be, right? They're accredited, they're very intense, there's a lot of intense supervision that goes on. So the spigot, so to speak, is really regulated, and we need more students. There's people interested because these are good jobs. We need more student scholarships, though. We probably need, and I know sometimes people cringe at this, but the way the accrediting system works in medicine and in other aspects of behavioral health, we need to hire more faculty because all the accreditation is related to student-faculty ratios. Rightly so, because it's intensively supervised.
But there is demand on the part of students?
Yes, maybe I shouldn't tell you this, but this would be true in the other behavioral health training programs, but marriage and family, clinical mental health, we turn away half our applicants because we would be in violation of our accreditation, and we couldn't do a very good job, frankly. So yes, the demand is there.
I want to recognize Cliff.
No, I just have a question.
Oh, you have a question? I thought you were saying cut it off. I was trying to be cognizant of you standing there with your hand waving.
Only because I've had a private conversation with kids. I wanted to get him to talk more about what he's doing with student athletes.
Yeah,
this
okay.
is in the news a lot.
Yeah.
Very high profile cases of suicide at Stanford. Tell us a little bit what you're doing in that area.
Yeah. Thanks, Cliff. We have this is cutting edge stuff, so I think we can feel good about some of the things you're hearing really are cutting edge stuff nationally. Our former athletic director, Carrie Groth, some of you may know, came to me and said, when I was dean of the College of Ed, and said, I want to do an athletic leadership program, which on the graduate level, because we have coaches, we have people that have already have their bachelor's degrees working at the university that really want to know about ethics, about proper treatments, about all sorts of things related to working with athletes, all the way from 10-year-olds up through pros, although, we don't run across many pros, but we run across a lot of college athletes in this community, and certainly at the university. So we said, yeah, let's do it. And one of the components that Carrie, and I talked about was the mental health component. So anyway, what do people working with athletes need to know about mental health? And maybe not surprisingly, they don't know much. That's just not a thing. And I was talking about how there are certain groups in our society where the stigma has dropped precipitously. Let's take middle school kids, for example. Generally, they want to, if you say, hey, would you like to talk to somebody? Often they say, yeah. Let's take athletes, not so much, or cops, not so much, or military personnel, not so much, although that is changing. I mean, everything is headed in the right direction around reduction of stigma. So, to your point, so we added this mental health component to this. It's graduate students interested in areas of athletic leadership on the master's level. They can get a graduate certificate or they can get a master's degree. And this Carrie's program is national. So when I delivered this mental health component last fall, we had people from all around the country. We had people working with pro teams, the Jets. They probably needed some coaching help. That's a joke there. Maybe they, I don't know how much we helped them there, but anyway, anybody that's sort of a Jets fan gets that. A lot of college coaches, too, some high school coaches. And they were very keen on this whole thing. Let me give you a statistic, though. So, as Cliff mentioned, there is sort of a crisis now, yet there's still a stigma. Let me give you the crises stats, a couple, and then I'll give you the stigma stat. And we're trying to break this down through educating and providing coaches with tools in which to refer and even intervene on a kind of that level, which they can do. Athletes trust their coaches. So let me give you a few stats. NCAA report, you could Google this, it just came out. NCAA 2022 report on mental health. 42% of the athletes they surveyed, huge study, said they had experienced sleep difficulties, up from 28%, 2018. 31% said they felt sad, up from 20%. 25% said they felt at a loss, up from 8%. Yet the stigma is still there. Here's a eye-popping statistic. 53%, I think that's an only, 53% reported that coaches take mental health concerns seriously. I don't think that's an impressive number. We got to kick that up. Yet, here's another stigma issue. Only 47% said they would personally seek mental health counseling. So, you know, there's an area that requires a lot of work because, as you know, we know, there's a sense of, hey, I'm okay, coach, I'll just run it off. Sometimes the coach says that, just run it off. You feel sad, you'll feel better after practice. So, you know, this is a group that we're working very specifically to help this whole initiative around, especially trying to intervene with coaches. Yes.
So there seems to be a lot of progress in research in psychedelics.
Yeah.
Associated with mental health and behavioral health.
Yeah.
In particular, it has shown that very promising in addictions of all kinds, depression, anxiety, and as a matter of fact, most of the prestigious universities are conducting studies.
Yep.
Not only here in the United States, but Canada, Europe, other countries in the Middle East. And it looks very promising. As a matter of fact, next year it looks like FDA is going to be approving certain psychedelics for use, medicinal use.
Yep.
I was wondering, in the state as well as locally, is there awareness and any kind of discussion in the organization about this? Because it looks like it could reduce cost of these kinds of treatments significantly. And not only that, their efficacy in terms of people getting well, in terms of how long it takes is like cut down to, rather than years, to just potentially a couple of 3 months. And these are where they get cured, not treated for the rest of their lives.
Yeah, it's a really exciting development. And myself, like many professionals, 10 years ago, sort of looked at it and went, right, it's the new fad, the new, like, it's going to cure everything thing. But some good research is being done, really. And the longer that goes on, the more long-term research and results we can look at for truly what is the long-term efficacy of this. But yeah, there's a lot of conversation at the local level. There are currently some ketamine clinics that function in town. There are a lot of us looking at more effective. There's some treatment approaches. So there's a little bit of bias in here from just my perspective as a psychologist and as an administrator. The initial phase, and I think this is true of many new treatments, right? The initial phase is there are those few people that kind of jump on the bandwagon early. Maybe the research isn't really there yet, right? But they're kind of those first people that say like, hey, this looks great. Either I'm going to make a lot of money off of this, or this is the next thing I want to help people, right? And so there's a wave of clinics that opened some time ago for people that maybe didn't know that much about treating behavioral health issues, and so they did okay. There were some problems, and now we're kind of in the next phase where people are doing a better job of standing up clinics with the right supports in place for people and the right follow-up and all of that. And I think the next phase, from what I'm looking at, is there are things like ketamine-assisted therapy is a great example, right? So it isn't just the person gets a ketamine dose X number of times in X amount of time. It is, let's develop a treatment that integrates what we know in other types of medication, right? Medication plus therapy typically is the gold standard for treatment of mental health issues. And so let's do that with this. And so there is a ketamine-assisted therapy that is a specific therapy approach that you'd use in conjunction with ketamine dosing. And so that is going through like clinical trial research at this point. So yeah, it's interesting, it's exciting, and a lot of us are looking at it for like, when do we want to jump on this? How? What's going to be the most effective way? Yeah.
And certainly the training programs are right on this, looking at some of the breakthroughs that are happening around the world and some of the studies that are being done in the United States. So it is exciting. People are talking about it, and it seems very promising, especially for areas, as you said, like depression and addiction, and probably others.
Are there universities in Nevada that participate in these studies with masks?
Yeah.
I'm not sure.
I don't know that. That's a med school question. I don't have the answer to that. I know they're very aware. I wouldn't be surprised if they have their toes in.
Gretchen? You have a question?
I have another question. So, knowing the investment that Montrêux members made in the Cures campus over the last year, what is the relationship going to be, knowing the numbers of the people who are living on that Cures campus who are suffering from a mental health disorder? What is the relationship with the focus going to be at the Cures campus?
Yeah, fabulous question, and we've been very strategic about that actually. That is a passion point for those of us at Hopes. So we are building a new clinic. We broke ground, as was mentioned. We're hoping to have it open by fall of 23, and it is going to essentially butt up against the CARES campus, and that was a strategic choice. As an FQHC, I believe it is not just our mission to serve people that are underserved, but I personally believe it is our mission and it is our duty to find those people and go to them and figure out innovative ways that we can serve them in ways that we haven't done a good job before. And so one of those is looking strategically about a location. And so we'll be right there by the CARES campus, and we're designing some of our treatment approaches to meet the needs of somebody that is living at the CARES campus, somebody that does not have a phone, that you can't say, come back Wednesday at 2 o'clock, because they don't know where they're going to be Wednesday at 2 o'clock and if they're going to be able to hitch a ride over there or not. So we'll have, on the first floor, we have walk-in services for both behavioral health and medical care for people that need, truly, I just need to walk in and get this wound looked at. I don't want to talk to anybody else. I don't want to be one of your patients. I just have this gaping wound that I need somebody to take a look at today and tell me, do I have to go to the hospital or not, right? Or somebody that is in a substance use crisis or suicide crisis. In behavioral health, there's often this window of opportunity where somebody is ready to seek help, right? And sometimes it's very, very small. And if you tell that person, like they've come to the door and they say, I really got to stop using heroin, I just woke up and figured this out, and you say, oh, that's great, come to our orientation meeting 2 weeks from now and we'll talk to you about that, they're gone, right? But if you can connect them with somebody right that moment and say, okay, good, let's have you see somebody today and figure out what we can get for you today. And so we're designing a lot of our services. We'll also have traditional services because we also serve people with traditional insurance, right? And we have a lot of people that are not homeless, right? But we will also have those services that are designed specifically for that. Did I answer that?
Yeah, that was great, thank you. I want to be cognizant of everybody's time, and I thought what I'd ask is just if each of the panelists wanted to have any final thoughts that you want to share, and we could start with you, Ken.
Thanks. I think my final thought is just going to sound repetitive to what I said earlier, which is that Nevada is making some really great strides in implementing the crisis response system. It's going to have a huge impact on folks in the state. I'm excited to see how it plays out. And as of now, 988 is live. So I hope you will share that and encourage folks in your life that might benefit from that to try the system, to try and utilize it. Again, they can call or text on their phones. If they want to chat, they do have to go through the national line, so that's a little bit, you just have to go, basically Google 988, and it will connect you with somebody that can, or connect you to a site that you can chat through. So I think that's my final thoughts, and I'm excited to see where it goes from here.
Thank you. Thanks for your great questions and for coming. And if you have further questions, I think all of us pretty easy to find. You could just Google me at the university in terms of my email.
They can call me.
Okay, thank you, Cliff. Thank you. Maybe just a message that we're working hard. We need to put our shoulders to the plow for sure, and we do want the state is doing what it can, but we want them to do more, certainly. We want the university to do more, and I guess representing the university, we are trying to increase access. We have goals related to the Surgeon General's advisory on the nation's youth mental health crisis. One is to increase access and effectiveness. So we're working to try to leverage interns, typically master's level, pre-graduating interns, and try to match them with community agencies that work with clients with the most need. For example, we're working with Step 2 right now. It's a women's addiction center. We're working with Boys and Girls Club. We're working with the Eddy House. We're working with Children's Cabinet. We hope to add other agencies where we can provide them with, in effect, more clinical hours for their clientele. That feels to some degree like a bit of a drop in the bucket, yet we're doing it. Not to compare us to Mother Teresa, but she said we do what we can. And so we're doing more than what we were doing before. And that's, I think, how we have to look at it, like your analogy. So to the extent that you're interested and you can, we appreciate teaming because, we need that.
Yeah, I guess my final thought is I wanted to thank Cliff for this, kind of being able to do this overview. This is really big picture stuff we're talking about, and we don't typically, I can't speak for you guys, but I don't typically, when I give talks and lectures and things, it's not typically at such a high level, broad overview for a general public population themselves, right? Which I think is fabulous because most of us, if not all of us, have had some sort of personal experience in the area of behavioral health with a friend's child, right? Someone in our own family, ourselves. And so we have a personal bit of knowledge and a personal bit of experience of trying to find services, of struggling through that system, of trying to figure out how to fix things. And I think to put it in that context, put our own experiences in the context of these larger efforts that are happening, I think is really helpful. It helps us come from like this very, very micro view up to this very broad view. And I think that's helpful in looking at something that is such a big challenge, is to have that more macro view of what's happening and think, how can I help this, or how does this fit in with the things that I believe and the things that I can do out in the world. So thank you, Cliff, for doing that.
I just wanted to thank first everybody who came and has stayed with us, since this is a very complicated and difficult topic. And then secondly, to bring this back around to where we started, which was the homeless problem and how we're addressing it. There's a book that I recently read that I think is tremendous. It was written by 4 researchers from the Pacific Research Institute in San Francisco. Looks like you know the book. Bottom line, somebody mentioned Houston earlier. Houston has reduced its homeless population by over 50% in the last, I don't know, X number of years, while every city on the West Coast, go up and down the West Coast, is seeing an increase in homelessness in light of enormous spending. Why is that? Because Houston has adopted a program that's similar to what we're talking about here of integration of services, recognizing it's not just housing. That has been the agenda of Newsom in California and nationally, but just giving somebody a place to live does not solve the problem. So we hope to be the next Houston and not the next other West Coast city. Thank you. Thank you.